Hello, everyone. My name is Holly Damute, and I'm with the Wound Care Education Institute, powered by Relias LLC. And I would like to welcome you all to the webinar today titled Nutrition from A to Zinc. Our program today is made possible by a grant from Shield Healthcare. This event has been created to provide an opportunity for education related to clinical topics that affect the wound care market today. WCEI is now a Relias LLC company and continues to have one goal in mind: to improve the management of wounds and ostomy for patients across the nation. We currently support over 20,000 alumni through resources, webinars, seminars, our conference, as well as certification courses in wound care, diabetic wound care, ostomy, and nutrition wound care. So before we jump into the webinar, I'd like to run through a few housekeeping items with you. For those of you interested in obtaining educational credit, you will receive an email from WCEI within 48 hours with the evaluation for this program. You must complete the webinar and the evaluation within 60 days from today to access your CE certificate. Double check your spam folder for these emails after 48 hours. There is a handout available for the presentation today. You can click the attachment in the handout section to download or print if needed. The actual CE presentation should last about 60 minutes. If you have any questions for our presenter, please feel free to submit them in the questions box at any time during the webinar. If time allows, we will have a Q&A session at the end of the webinar. You must be logged in on a computer, tablet, or mobile device and viewing the slides. No credit will be awarded for those who use audio only. The accrediting body for this program is on the screen now. And now I would like to introduce today's speaker. Dr. Nancy Collins is a wound care certified dietitian based in Las Vegas, Nevada. Dr. Collins is nationally known for her expertise in the complex relationship between malnutrition, body composition, and tissue regeneration. She has over 25 years of hands-on practitioner experience in clinical nutrition and consulting, and is nationally regarded as a medico-legal expert dealing with the issues of regulatory compliance and the applicable standard of care in negligence, wrongful death, and malpractice lawsuits. Dr. Collins has a long history of service to the nutrition profession and has served as a president of the Florida Dietetic Association, chair of the Nutrition Entrepreneurs, and as a delegate in the House of Delegates, among numerous other positions. She is currently the Academy of Nutrition and Dietetics representative to the Alliance on Wound Care Stakeholders and the National Pressure Injury Advisory Panel. Hello, Dr. Collins, and welcome.
Thanks so much, Holly. Let me get situated here. Okay. Well, we're going to get started now, and I'm very excited to be here today. I want to thank both Shield Healthcare and the Wound Care Education Institute for inviting me to speak to you about my favorite topic, which of course is nutrition and wound healing. And what we are going to do today specifically is discuss the nutritional components that are necessary to fuel that wound healing process, to build that new tissue. And I'm trying to keep today very practical so that you can have some ideas on how you can easily do this for your patients, whether you're a dietitian or a nurse, whatever setting you work in. In order to do that, you have to understand a little bit how poor nutritional status impacts the body's ability to heal, and then hopefully you'll walk away with at least 2 new strategies that you can implement at your own facilities. So let's go ahead and get started here. And where would we start with such a big topic? Well, let's start with the idea of an optimal diet. What is that optimal diet for wound healing? I think that if you ask 10 different people, you might get 10 different ideas, but we do have some clinical practice guidelines that guide us in the direction of an optimal diet. The problem that I run into with my patients is that how often are they eating that optimal diet every day? So as a dietitian, I have a lot of different tips and tricks that I can use to guide them gently into eating more of the types of foods that they need to heal that wound. The problem is that I see a lot of patients, and I'm sure you do as well, that are malnourished or at risk of malnutrition. They're simply not eating well for a variety of reasons. Perhaps they just don't feel well. That, of course, is what happens when you have some sort of an illness. And my patients don't just have a wound, they have all sorts of other diseases as well, a lot of comorbidities. So they are not taking in enough calories, enough protein, enough of the nutrients that are needed to repair their tissue and heal that wound. And that's called undernutrition. And so we have to address that. So it's not so much just knowing the optimal diet, it's how do we get that into the patient. And to me as a dietitian, that of course is where the challenge comes, because it's not just one day that I need to do this, it's every day. We need to get them in enough calories. Let's start there. They need energy. Wound healing is a very energy-dependent process. It takes a lot of energy to build new tissue. Calories is another word for energy. When my patients are not taking in an adequate amount of calories every day, what happens is, of course, that they lose weight. And I'm sure that you see a lot of patients who are losing weight. It may not be dramatic. Maybe it's a slow downward trend. They're losing just a little bit over time each week, a little bit, because they're not eating an adequate amount of calories. The problem with losing weight is that most of these patients are not particularly losing fat. They're losing lean body tissues. And lean body tissue loss is very detrimental to wound healing. So let's talk about that for just a little bit. In order to understand that, you need to understand a little bit about body composition. Okay? For simplicity's sake here, let's say that the body is made up of your fat mass, your bones, and your muscle mass or your lean body tissues. That is your total body weight. Okay, so when you go on a scale, what you are seeing is your total body weight. It's not necessarily telling you what that weight consists of. It's just a number on a scale. I'm sure some of you dread that number. Some people don't want to weigh themselves, but that's the number. That's your total body weight. Now, when we're talking about our wound care patients, I'm not so concerned with that total number. What I'm more concerned with is what is making up that number. So let me give you a little example here. Which weighs more, a pound of bricks or a pound of feathers? Okay, it's a little bit of a trick question. A pound is a pound is a pound. But you can see the brick is all tightly packed and very dense. I could carry that brick around in my purse and you wouldn't even know it, that I have this small compact brick in my purse. A pound of feathers, of course, it still weighs a pound, but the volume of that is going to be much greater. I can't carry this whole pound of feathers around in my purse. I would need several hefty bags to carry a whole pound of feathers, and that would be quite cumbersome. So a pound is really not a pound, is a pound kind of thing. It matters what that pound is made up of. Now, when we apply this to our patient population, here's some typical examples of patients that you might see. Well, you might take a look at this lady and say, wow, she's kind of thin, looks a little bit frail. Clearly, she needs some nutrition intervention. I think that that's what we all would think. She's got this wound that doesn't heal. She's got other diseases and comorbidities. She's thin. We've got to do something nutritionally for her. But we put the gentleman on the scale, and his number, that scale number, is even overweight. And so it goes down on the chart that his body mass index, his BMI, is in the obesity range or the overweight range, and check, he's good on nutrition. So I'd like you to stop and think about this for a minute and have a little bit of a paradigm change in your own minds. This is not really the case. He's almost as depleted as the lady is. His body composition, what does he look like he's made up of? Does he look very strong? Does it look like there's a lot of muscle there, a lot of lean body tissues? No. He looks kind of doughy maybe, or has a bunch of adipose tissue, which is metabolically inactive. So while his scale weight is of an appropriate weight, his body composition is not where I would like it to be. So he needs nutrition intervention just as much as she needs nutrition intervention. And a lot of times when I'm reviewing charts, I see that people just solely go by that scale weight number. And because his number is high, that kind of equates to, okay, he's fine nutritionally and we don't have to do anything. But yet he's got the same comorbidities, he's got the same wound that's not healing, but yet he doesn't get the same nutrition interventions as she would. So you have to really kind of look beyond the scale and not concentrate so much on that number, but really try to get a little bit deeper into this, into the issue of body composition. So I hope that that kind of gives you a little aha moment and tells you that just because someone's number is high does not mean that they don't need nutrition information. Now, why is this important? Why would this even matter? Well, it matters because there's a relationship between lean body mass loss and wound healing. And there's plenty of research out there. You know, researchers have spent their entire careers trying to figure out this link. And what we now know is that when patients are losing lean body tissues, what happens is that there becomes a competition for the nutritional substrate. It's not a normal situation to be losing your lean body tissues. You have to remember your adipose is metabolically inactive and your lean tissues are where all the action takes place. That includes your vital organs, your skin.
Hi, everyone. It looks like we've lost Dr. Collins's audio for just a moment. We are working to get that back up with her. Give us just a moment and we will get her back on. Thank you for your patience. We're working with her to get that back up. Thank you again for your patience. Just taking a moment to get her to dial back in. We are seeing a bunch of questions about the audio. We do understand that there isn't anything right now. We're just trying to get Dr. Collins back on the line.
Holly, I'm here.
Wonderful. I think we lost you about halfway through this slide.
Okay, nothing like technology to go wrong, but let's continue here. Okay, so we'll just start over here. The relationship between lean body mass loss and wound healing is something that has been studied extensively. And what we know is that if your patient is losing lean body tissues, that's not the normal situation. You should not be losing your lean tissues. So their body has an impetus to restore that lost lean tissue because your lean tissues include all of your metabolically active tissue. That's your heart muscle, your lung muscle, those intercostal muscles that run between the ribs to work the lungs. That should not be wasting away. If it continues to waste away, of course, the patient ultimately will not survive. You can't just continue to lose your lean body mass. So when your patient has lost less than 10% of their lean body tissues, at that point, wound healing has the priority for the protein substrate. But if you let this weight loss and this lean body tissue loss continue unchecked and it reaches greater than the 10% level, at that point, the body has to say to itself, what should I do with all of this nutritional substrate coming in? Should I put it towards healing the wound, or should I put it towards keeping this patient alive? And of course, keeping someone alive is going to take the number one spot over the wound. And as you reach that 20% loss of lean body tissues, at that point, wound healing ceases and their body has no choice but to restore the lost lean body mass. So this is why it's very important that even if your patient weighs a lot, that you do take a look at their lean body tissues, and they need to have an adequate amount of both calories and protein in order to restore that. So how many calories are we talking? Well, according to the clinical practice guidelines, about 30 to 35 calories for every kilogram of body weight. And this is for adults who are at risk or with a pressure injury. Okay, so what does that mean? That's kind of a random number. If you're not a dietitian, that might seem kind of nebulous to you. Well, 30 to 35, what exactly does that equate to? So I wanted to put that in some real terms for you. So if you have a 125-pound patient, of course, changing that to kilograms, that's 56.8 kilograms. And using these numbers, what that would mean is this patient requires every day about 1,700 to 2,000, 1988, about 2,000 calories a day. So let's just stop and think about that for a moment. That's quite a bit of calories. 1,988 calories. I don't have a lot of patients who are eating a great deal every day. This might be very difficult for them to reach. So how do we do it? Well, before we go into some specifics, I just want to remind you that you all have good clinical judgment and your own critical thinking skills. These numbers that we're going to discuss today are the general guidelines. And as we know, with all of these general guidelines, they're written for the many. You are treating the one, and your one might have slightly different requirements. I don't know exactly what's happening with your particular patient. Maybe they are on the brink of needing dialysis and they're having some renal impairment. And the amount of protein we're going to discuss in a moment is going to be simply too much for somebody in that situation who wants to preserve their renal function for as long as possible. I don't know what's happening with your particular patient. So please always keep in mind that these are general guidelines and you need to apply your own clinical skills to adapt these for your particular patient. Okay, so that said, how can we increase calories for someone who needs about 1,700 to 2,000 calories a day? Well, depending on the environment that you work in, there's different, tips and tricks, I like to call it. You can increase the caloric density of the meals. A lot of my patients, I work with a lot of older patients, long-term care patients, they don't want an enormous amount of food in front of them. They would prefer a smaller amount, so I have to make that the most bang for the bite. I have to get as many calories as I can into them with the smallest volume of food. If I serve them a overflowing tray of food, they look at it and get turned off. So I can make a bowl of soup that's 200 calories, or I can make a bowl of soup that's 500 calories. I'm sure you probably sometimes do this in the reverse. A lot of people are on the opposite. They want to lose weight. So what do? You modify your recipes to make them lower calorie. I make brownies and I don't put any of the fats in it. You can replace it with applesauce and make low-calorie brownies. Well, you can do the opposite and make things more caloric. So that's one little thing you can do. Making sure that they have their favorite and culturally appropriate foods. You know, this is a very multicultural society we have here these days. So making sure that they have the foods that they like, that they're used to, that are comfort foods. Maybe that will encourage them to eat more. And depending on, again, your care setting, perhaps they're on a very restrictive therapeutic diet. And maybe now is not the time when they're trying to heal a wound to have such a restrictive diet. Perhaps we need to liberalize that diet, give them more choices to eat. In long-term care, particularly, getting people out of their rooms for meals to a dining room where they have maybe more supervision in a dining room and socialization that can encourage people to eat better. Providing assistance and encouragement, small meals and snacks throughout the day. And if all of these things you're still not getting enough calories into someone, you can use a high-calorie oral nutrition supplement. These are your canned or bottled, usually high-calorie, high-protein drinks that can fill in the nutritional gaps for somebody. So you really have to try all different angles, again, depending on what's happening with your particular patient. And what's really important also is to make sure that even these kind of common sense and lower level food interventions get into the chart. A lot of times when I'm reviewing charts, typically when I'm reviewing charts, it's because there's been some sort of a problem. And a lot of times I don't see that they've taken credit. They, being the staff members, have taken credit for these kind of lower level food interventions. If you're doing these things, you should get them in the chart as an intervention so that you get credit for them and shows exactly what you're doing to encourage a good intake. Now let's move on to protein, because protein is a big topic when we're talking about wounds. Protos. Protein comes from the Greek word protos, and that means first or primary. This is kind of getting to the point of the body's fundamental need for protein. Protein is different than the other macronutrients, which of course are protein, fat, and carbohydrates, because protein is the only macronutrient that has nitrogen. And nitrogen is very important in wound healing. We want people to be in what's said a positive nitrogen balance. And in order to do that, they're going to have enough protein substrate. Okay, so there are 30,000 different types of protein. They all have different jobs, and these are the building blocks of amino acids are the building blocks of protein. All of your protein is made up of strings of various amino acids. And what happens here is you eat the whole protein, whether that's your piece of chicken, your steak, your egg, and your body digests it. It goes in your mouth, it goes down to your stomach, the process of digestion takes place, and it breaks down that protein into the component amino acids. So I kind of think of this as, a pearl necklace, if you will, where all those different colors on your screen are different pearls. And what happens is that it breaks them apart and then reassembles them into different order. So if your body needs it, it will synthesize what it needs. If your body doesn't need it, if it has an adequate supply, it filters out the excess through the liver and the kidneys. And this, of course, is a very simplified schematic of the process of digestion. Now, here's the 20 different amino acids. In case you have forgotten some of your nutritional biochemistry, there are 20 different amino acids, and your body makes some of these, and some of these it has to get from food. But we'll talk about those in just a moment. And your DNA is what provides the instructions for how these amino acids will be linked. And these then form the various proteins in your body. And what we've been able to learn is that some of these amino acids are very, very important in the wound healing cascade because they have various jobs. And we'll discuss those in just a moment. But first, let's talk about how much protein are we talking of this whole protein? Well, again, looking to the guidelines for some guidance here, about 1.25 to 1.5 grams of protein for every kilogram of body weight. And again, this is for adults and adults who are at risk of a pressure injury or with an existing pressure injury. So again, if we go back to our 125-pound example, this would mean if you're using 1.25, about 71 grams, and at 1.5, about 85 grams. So, but to me still, and I'm sure to you, grams, what the heck is grams? It's hard to think about food in terms of grams because we just don't do that here. So you have to keep in mind there's conversion factors. And I put this up for you just in case you're not familiar, but for an example, there are 7 grams of protein in 1 ounce of cooked meat. So if we're talking about a raw 4-ounce boneless, skinless chicken breast, after you cook it, it will be about 3 ounces, and 3 times 7 is 21 grams of protein. So that is how you would calculate that. And if we calculate this for our example, this means that our patient will need about 10 to 12 ounces of a high protein food each day. Again, probably a challenge. That's quite a bit. How are we going to accomplish this? Well, of course, I would like to see food eaten first. That's your beef, your fish, your pork, your eggs, your milks, all of your foods that contain protein. But again, if you cannot get enough protein in, there's plenty of protein in our oral nutrition supplements. The key here, a lot of times when I'm looking at charts, is that they order the protein supplement or they order the oral nutrition supplement, and then a couple of days later, they discontinue it. And there's a brief note that says, discontinued supplement, patient didn't want it, patient wasn't drinking it, patient refused, something along those lines. But again, these days, you have to go a little bit further to show what you've done to encourage them to drink this or to consume it. If it's whatever it is, a cookie, a yogurt, a shake, a bar, a pudding, there's many different textures out there, something for everyone. So take it out of the can or bottle, serve it cold over ice. There's no reason you have to serve it in the bottle or the can. If you put it in a glass or even a glass with a stem, it looks entirely different. I like to keep those spray cans of whipped cream around. If you pour it in a glass and you spray a little dollop of whipped cream on the top, which takes, 2 seconds to spray, it looks like a very nice, attractive treat. And people tend to consume it better. People eat with their eyes first. You can take your vanilla and you can flavor it with whatever you've got around, some sort of powdered drink mix, instant coffee granules. I have a guy that mixes his vanilla with peppermint schnapps. So there's plenty of ways you can change the flavor using vanilla as your base. If you're giving someone medications, give it with a high-calorie, high-protein supplement instead of water. Why would someone just wash their pills down with water when it's a little chance to sneak in some extra calories and protein? And again, there's many different textures. If someone doesn't want to drink that big glass of something, you can give them a high-calorie, high-protein cookie. There's a whole industry out there making different products for you to fill this need. So if you haven't tried some of these, really all you have to do is call the various companies and ask for some samples, and I'm sure they'd be happy to provide them. And then, of course, we can just use a protein supplement. There's an entire aisle of protein supplements at your big box stores, liquid proteins, powdered proteins, in a variety of different flavors. I like often to use a liquid protein. You can get in just a very small 1-ounce serving of a liquid protein, depending on the product, 10 to 15 grams of protein. That can definitely help reach that goal every day in a very, very compact form. You know, a lot of my patients, again, are more elderly and in long-term care, and I use a cherry-flavored product. So often they don't even realize it's a protein supplement. They don't know what it is. I've had many people tell me, oh, is that my cough syrup? And they just down the hatch. It goes because it's just such a small amount, a concentrated source of protein. Don't want to buy a protein supplement? Well, you can use eggs. Eggs are obviously very inexpensive. I think I saw in our flyer here for our local supermarket, $1.99 for a dozen eggs. It is the least expensive source of high quality protein, maybe about 15 cents each egg. It's nutrient dense. When we score protein, there's a whole grading system for protein. Eggs have the highest score, 100. That means it has all of the amino acids in it. It's a good blend. It has everything you need. It's portion control. What I encourage my patients to do if they're in a home setting is on Sunday night, you hard boil the entire dozen eggs, peel them, put them in your little storage container in the refrigerator, and then for the next several days, you have your eggs ready to go, and it is a high quality source of protein that you can take with you. You can eat during commercial breaks, when you're watching television in the evenings, but it's a good little snack that you can incorporate. And if you make them once a week, you make the whole dozen, you've got snacks ready to go. Now, the other thing besides getting an adequate amount of protein in is, well, we have to also consider that as you age, the body's ability to synthesize protein from the nutritional substrate goes down. We know that as you get older, your synthesis rates are lower than when you were young. Your ability to generate new lean body tissue is decreased. You know, as you get older, everything gets a little tired and your systems aren't working as efficiently. So there are ways that we can also increase protein synthesis, trying to get that system to work a little bit more efficiently, that protein synthesis pathway. So we already talked about the quantity of protein. We want to make sure they have enough substrate, and the quality of the protein. Like we said, the egg is very high quality protein. But there's a couple other ideas here where we can try to increase protein synthesis. So here's one that you might not be familiar with. It's the way we distribute the protein throughout the day. Okay, so here's someone who is eating what they would consider to be a pretty healthy diet of 90 grams of protein each day. Breakfast might be that bowl of oatmeal with a little splash of milk in it with some fruit. And they think, well, that's a very nice breakfast. I'm having whole grain oats and some fruit, a little bit of milk. Lunch might be their half a tuna sandwich or a little salad with some meat in it, about 15 grams of protein, and the bulk of the protein comes at the dinner meal. That, I think, is a pretty normal way that a lot of people may eat. You can see the red dotted line is the maximum rate of protein synthesis. This is where your system is at its maximum. But you can see eating in this pattern, you only reach that red dotted line a very small portion of the day. So there have been studies done that show, well, what if we can distribute the protein more evenly throughout the day? Here's 90 grams of protein again, so we haven't increased the amount, we've just distributed it more evenly. And by doing so, you can reach that red dotted line, that maximum rate of protein synthesis, all throughout the day now. So if you have a more elderly patient whose system maybe is not working so well, having their amino acid pools empty out overnight while they're sleeping, and then have, let's say, their tea and toast for breakfast, that's not helping heal their wound. It's not helping them synthesize any new protein. In that case, if I have someone who only wants tea and toast for breakfast, I'm probably not going to be able to change their mind, so I'll make sure to give them their liquid protein supplement at breakfast time. You have to time it so that they'll get their supplement at breakfast. And so by doing this, you can help them synthesize protein at a better rate. So distribution of protein is something easy to do. We're not giving anyone any more here. We're just making sure it's distributed a little bit better throughout the day. Now, the reason for this is because we don't want those amino acid pools to empty out. Now, here's the 20 amino acids again for you, but listed in a little different format here. The first column, those first 9, are your indispensable amino acids. You can only get those from food, from an exogenous source. No other way to get those 9. From those 9, again, that process of digestion that we spoke of, from those 9, your body will make all the others. The middle column is the dispensable amino acids. Your body will make those 5. And then the last column, your body will make these other 6. These are the conditional amino acids, conditionally indispensable. So what makes them conditional? Well, what we know about these 6 is that, yes, your body can manufacture its own supply of these, but in times of stress, in times of trauma, in times of inflammation, in times of illness, your body's demand for these in particular go up. And your body might have trouble keeping up with the increased demand. Your body needs more of these, and maybe it can't keep up with that increased demand. Now, the 2 that are closely tied to wound healing are arginine and glutamine. So we need to look at those in particular. Now, again, every day you're eating food, hopefully, and from a typical diet, you're taking in about 5 to 7 grams of arginine a day. Then your body will produce additional arginine, about 15 to 20 grams a day. That's your endogenous production of arginine. But again, if your patient has any sort of critical illness or any sort of stress, such as this chronic wound that doesn't heal, or they've had surgery, or maybe a heart attack or a stroke, something has happened, we know that the body's ability to produce its own arginine is reduced to about 1/3 of the normal level. And then the disintegration or the breakdown of arginine is upregulated about 4-fold. So you're producing less and you're breaking down at a faster rate. So therefore, we go ahead and we supplement this. Why would we supplement it for wound healing? Well, arginine has many roles in wound healing. It is needed for nitric oxide production. You can't have wound healing without nitric oxide. There's no sense in building new tissue if we don't have the blood flow to that new tissue to keep it alive. And arginine helps do that, helps increase that blood flow. It also is bactericidal. It helps keep those wound infections low in the wound bed. It's used by the macrophages and the leukocytes to destroy the pathogens. So there's many reasons that arginine is key to that wound healing cascade. You need it to trigger a lot of these things to happen. And if your body runs out, not going to be a good situation, so we supplement it. Often along with glutamine. Glutamine is the most abundant amino acid in the body. We make a lot of glutamine every day, but we use and break down a lot of glutamine every day. If you've ever worked in a critical care or a trauma setting, I'm sure you're very familiar with glutamine because it's been used in those settings forever. As long as I can remember, it's been used in those settings. Why? Well, because this is one of the ways that we can regulate the nitrogen metabolism. If your patients are breaking down their lean tissues, they're not eating enough, they're losing weight, they're on bed rest, they're losing lean tissues for a variety of reasons, that's called catabolism. They're in a catabolic state. Wound healing, by its very definition, what's the definition of wound healing? Build new tissue. What's the medical word for building? That's anabolism. We need them to be in an anabolic state. If you want to heal a wound, you're not going to do it while you're catabolic. You have to be more anabolic. And glutamine is one of the ways that we can gently guide somebody into a more anabolic state. It helps regulate that nitrogen metabolism. Remember, we said we don't want somebody in a negative nitrogen balance. We want them in a positive nitrogen balance. And glutamine is one of the things that we use to help get us there. It also stimulates collagen synthesis. We use it for immune support and gut integrity. So glutamine, something that's been around for years, and now we often use it in our wound patients, again, in combination with arginine, to help get them into a more anabolic state. Now, one of the others that I haven't mentioned up to this point is leucine. Leucine is one of the branched chain amino acids, and it's not so much leucine that I'm interested in, but a metabolite of leucine that's called beta-hydroxy beta-methylbutyrate, otherwise known as HMB. About 5% of leucine ends up as HMB. Okay, now you might not be familiar with HMB. This might be something that you haven't heard of yet. If you look in Google after this and say, what was that HMB she was talking about today? The first several pages of your results will be centered around the exercise world. A lot of people in the gym environment use HMB. That's where it started out. In order to lift heavier weights, more repetitions, less recovery time, they would use HMB to help protect their muscle from breakdown while they're stressing it during exercise. That's one of the early uses of HMB. Where it went from that, we're going well back into, the 1980s when the HIV and AIDS crisis first started. Those patients were losing a lot of weight, and they were really, truly wasting away. We don't have that problem so much now with some of the drug cocktails that we have, but they were wasting away. And they thought, well, what can we give these patients to try to protect their muscles from breaking down? And HMB was studied in that environment and used with success. And then, a cancer researcher said, well, I've got cancer patients who are also losing great amounts of weight. Maybe I can use it in that environment. And studies were done in that environment, and so on and so forth. And now we use this often in wound care patients because they've got the same situation. They're on bed rest. Their body is under stress and inflammation. We want to protect their muscles from breaking down. And again, why would we do any of this? Because we don't want them in that catabolic state. We want them in a more anabolic state so they can build new tissue to heal the wound. So HMB, how it actually works is in the cell wall, and it helps protect that muscle cell wall from breaking down under stress. Okay, water. Okay, we've got to make sure that everybody is hydrated as well. Water gives this feeling of fullness and the shape to our body tissues. It helps maintain the blood volume, carries the nutrients in the waste. I'm sure that you all have felt dehydrated maybe after flying or cross country or being in a very hot and humid environment, and you get that impetus, that thirst mechanism kicks in. Unfortunately, for some of our patients, that thirst mechanism does not kick in. So it's very important that we make sure that we're providing an adequate amount of fluids to our patients each day. Women are about 50 to 55% water, and men are about 55 to 65% water. Quite remarkable when you think about it, that fluids are so important here. So how are we going to do this? Well, we want to prevent dehydration. That is definitely a risk factor for pressure ulcer development. Also, if your patient has vomiting or nausea, or perhaps they just can't hold the cup and so they don't drink on their own, they need somebody to hand it to them, or maybe they've got a urinary tract infection. Many, many different situations here on why somebody might become dehydrated. One of the things specific to wound healing is if they're on an air fluidized mattress. Those mattresses generate heat, and that can cause some excess moisture evaporation from the skin. So if your patient is on this kind of specialized bed, they might need additional fluids to compensate for that. And I think that that's something that's often overlooked, that some of these treatments, they might need some extra fluids for, or if their wound is heavily draining. So again, where we were talking about the general rules, here are specific situations that might apply to an individual patient where you have to adjust their fluids. So how much? Well, there's two different methods to calculate this. Kind of the simple method is to provide 1 milliliter of fluid for every calorie that we're recommending. So remembering when we gave you the example of a 125-pound patient, we were recommending 1,704 calories to 1,988 calories. That would equate, if we're just using a 1-to-1 ratio, to 1,704 milliliters of fluid to 1,988 milliliters of fluid. The other way, probably maybe a little bit more scientific way, is again to base this on their body weight. And generally, most people require about 30 milliliters of fluid for every kilogram of body weight. So doing it that way, you can see in ounces, I've worked this out for you, it's about 56 to 66 ounces. And if we break that down to 8 ounces in a cup, that's about a little more than 7 to about 8.5, let's say, cups a day. Now, again, you have to really think, in real terms, what is your patient actually drinking? Or what are you even drinking? Are you drinking 8 cups a day? This might be a stretch for a lot of people. But if you want them to heal their wounds properly, it's very important that they get this amount of fluid every day. So how are you going to do that? I always like to try to be practical and leave you with some ideas of how you're going to do this. It's one thing to know that they need it, but unless you can accomplish it, it doesn't do anything. So again, depending on your care setting, if you're working in a home care environment or someplace where people are watching television, tell them to take some sips during every commercial break. People tend to like cold beverages cold, hot beverages hot. Nothing worse than drinking your coffee and it sits there for 5 minutes and it already is turned cold. I've got a friend who every 10 minutes is sticking their coffee in the microwave, trying to keep it hot. Keeping the fluids nearby, offering them frequently. Again, when taking medications, taking a larger quantity of liquids with the medications rather than just that one little sip of water. Maybe taking a bigger cup of water. And again, it would even be better than water, your high-calorie, high-protein supplement with your medications. Good time to remember to drink. Using diuretics only if they're truly needed. Addressing the fear of incontinence. This is a big issue, particularly in long-term care. I've had many, many patients who self-limit their intake of fluids because they don't want to go to the bathroom too much. They have told me on many, many occasions they don't want to go to the bathroom. There's nobody to help them. They're afraid of going into bed or not getting to the bathroom on time. So they limit what they're drinking. And that has to be addressed. If that's somebody's fear, that's obviously a valid fear, and we have to address it. Helping to provide independence for drinking, whether that's a cup with a handle so they can hold it, or a straw if that's indicated for them, or an angled mouthpiece. There's plenty of specialized cups that you can buy that can make it easier for somebody to drink independently. Caffeinated and alcoholic beverages might contribute to dehydration, so you might want to limit those. And then remember that it doesn't actually even have to be a liquid. There's high water content in a lot of different foods. That could be a gelatin or some sort of a fruit ice or a popsicle or, some sort of ice treat. As watermelon has a lot of water in it. That's why we call it watermelon. So there's a lot of foods also that can contribute to meeting their fluid needs, not only liquids. So again, depending on what your patient likes, there's something out there for everyone. Now, the next thing you need is vitamins and minerals. Of course, as they say, most nutrient needs can be met through a healthy diet. Again, the problem is who is consuming this optimal diet every single solitary day. So often we want to supplement. I'm sure that plenty of you listening today take vitamin and mineral supplements. I think that a lot of people take a multivitamin just as an insurance policy. Certainly we're entering the cold and flu season. A lot of people are taking additional vitamin C, thinking that it will help keep them feeling better through the cold and flu season. But when you have some sort of a pressure injury or some sort of a wound, your vitamin or minerals again, are cofactors for a lot of the reactions that have to take place to heal this wound, and we don't want people getting deficient. Now, we don't have time to go over every single vitamin and mineral, but I think that most times people want to hear about vitamin C. So let's talk about that a little bit more. Vitamin C is water soluble. You need it every day. If you take in too much vitamin C, it will just be excreted in your urine. Why do you need it for wound healing? Well, it is the cofactor in a very key hydroxylation that needs to take place. Proline and lysine need to be hydroxylated to hydroxyproline and hydroxylysine in order to form new collagen. And vitamin C is the cofactor, or you can think of it as the trigger that makes this happen. So if you run out of vitamin C and this doesn't take place, obviously you're not going to build new collagen. And the other thing that's very interesting is that sometimes you can build new collagen, but it's not very high quality. How many times have we seen a patient who has healed a wound, and then lo and behold, that same area reopens and we're right back to square one? We want collagen that's built, that's strong, that stretches. That's the beauty of skin. It stretches. You can bend your knees. You can smile. You can bend your arms. Skin stretches. It needs to have tensile strength to do that. And so how do we provide tensile strength to newly built collagen? Make sure that they have enough vitamin C when they're healing. And as I've already mentioned, it has to do with immune function. I think that that's a pretty well-known function of vitamin C, and several other things that are necessary. You need it to synthesize carnitine. That's what transports fat to the mitochondria. It protects iron in the intestines from oxidation. So there's many different functions of vitamin C. The question is, of course, how much? And do we give every person with a wound vitamin C? So those are the things we need to answer. Let's start with the RDA. That's as good a place as any to start, even though the RDAs were built on healthy people, and we know that most of our patients would probably not fall into that category. But the RDA, for reference, is 75 milligrams for women and 90 milligrams for men. The upper limit is 2,000. Okay, so in a practical sense, I don't think that anyone is getting harmed from vitamin C. As I said, it's water soluble, and if you take in too much, your body will excrete it. Nobody's having too many adverse events occur from taking some vitamin C. It's not very expensive. You can go again to your local big box store and buy a big bottle of vitamin C for $9.99. So it's not going to break the bank. But can I sit here and tell you I have a lot of research that shows that additional vitamin C enhances wound healing. Those studies just have not been done. There's nobody doing a multi-million-dollar study on an item that costs. It's just not happening. So what do we do in this situation? Well, I think that we don't want anyone to become deficient in vitamin C. And again, encouraging them to eat foods that are high in vitamin C is a good idea. And in case you're not familiar with those foods, there's a wide variety of them beyond your citrus foods. You can bell peppers, broccoli, strawberries, pineapple, cantaloupe, cauliflower, all high in vitamin C. So we want to make sure that people are getting an adequate amount of vitamin C every day. But there's no real data out there that shows that additional supplementation is warranted. Certainly, I sometimes tend to give it because, again, no one's having an adverse effect. It does other things as far as immunity and things like that. So it's up for you to decide what that individual patient needs. But again, when we look at the research, no indication that additional is needed, but we don't want someone to become deficient. Zinc is not quite as simple as vitamin C because zinc is not water soluble. It is stored in the body. Okay, so that's a different situation. We know you need zinc for RNA and DNA polymerase. Again, this is something that is a cofactor in many of the reactions that help heal wounds and build new collagen. You need it for cell membrane repair and cell proliferation. There are many things that zinc does. Again, we don't want someone to become deficient in zinc, but there's no real evidence that shows that additional zinc beyond that is necessary. And one of the things that I like to always caution people is that you might be giving more zinc than you even realize. So you have to read the labels. The problem with giving too much zinc is that you can accidentally cause a copper deficiency. Okay, zinc and copper compete for the same binding sites on the cell. So if you flood the system with zinc, you can accidentally cause a copper deficiency. So we have to really look at the total zinc that somebody has a day, their cumulative zinc intake. So let's look at the RDA again. The RDA for zinc is 8 milligrams a day for women and 11 milligrams a day for men. The upper limit is 40 milligrams. Okay, so you might be reaching that 40 a little easier than you think, because let me show you how. Well, everyone's eating some food, so there's some zinc, of course, in their food. And you might be giving a multivitamin. That has zinc in it. You might be giving some of the oral nutrition supplements. If you're giving 2 cans or bottles of that a day, look at the label. Depending on the product you're using, that might be another, maybe 10 milligrams of zinc in each of those cans or bottles. You're giving some amino acid supplements. The amino acid supplements that we use today sometimes have zinc in it as well. If you use the combination of arginine, glutamine, and HMB, there's zinc added to that combination. So you can easily be approaching this 40 milligrams a day without too much effort. So do they actually need an additional zinc supplement? Often the answer is no. And again, zinc is stored in the body. When you're giving a 220 milligram zinc sulfate tablet, sometimes people don't realize what they're giving. Zinc has to be bound to something else. And typically, pharmacies in most of the healthcare facilities stock zinc sulfate. Zinc is bound with sulfate into a tablet. The tablet in total is 220 milligrams, but of course, some of it is zinc and some of it is sulfate. There's 50 milligrams, 50 milligrams of zinc in every one of those tablets. So you can see that's already above the upper limit. And if you continue to give that every day for an extended period of time, it will eventually affect someone's copper status, and you can be creating an anemia inadvertently. You know, I have this one patient that I was looking at their chart, and they had been on zinc every day for a year. That's definitely not indicated. And of course, at the same time, their wound was not healing. So you want to definitely monitor somebody's zinc status. And if you suspect that they might be deficient, you might give them a supplement to correct that deficiency. But make sure that it's not indefinite and that you're measuring the therapeutic response to that supplement. If their wound healing suddenly starts improving, well, maybe they were deficient and you've corrected it. If you're not making any progress or the wound even gets worse, you probably need to discontinue that, and perhaps they were not zinc deficient. Foods high in zinc, of course, that would be a good way to get the zinc. Maybe some of these things are not the most common foods, but this is where you find your zinc. Oysters, chicken legs, pork chops, lentils, oatmeal, beef, tofu, hemp seeds, wheat germ, mushrooms. That is a variety of foods that have a high zinc content. So when we put all of this together, we have our nutrition from A to zinc. We've talked about calories and body composition and protein and all those things, so let's just review here and see where we're at. Did we cover really from A to zinc? Well, amino acids, body composition, calories, dehydration, energy, fluids, glutamine, HMB, their intake, judgment, your clinical judgment, kilograms per body weight, leucine, minerals, nitric oxide, oral nutrition supplements, protein, quality, RDAs, synthesis, toxicities, undernutrition, vitamins, water, exercise, yolks, like in your eggs, and zinc. And I think that we've got it nutrition from A to Zinc. So hopefully you've walked away today with some ideas of how you can accomplish this into your regime, whether you're working in home care, acute care, long-term care, plenty of different ideas for you to try. So I will turn it back over to our moderator, and we'll see if we have some time for questions and answers.
Thank you, Dr. Collins, for such a wonderful presentation. This concludes the CE portion of this webinar, and we'll move on to our Q&A session. You may begin typing your questions into the questions box at this time. And while we're waiting on your questions, I'm going to go ahead and send out a poll to everyone right now. WCEI and Relias would like to know if you're interested in more information regarding our skin and wound management, diabetic wound management, ostomy management, or our nutrition wound management courses. Please select yes or no to learn more about the courses we offer to further take the next step in your career. And we'll leave this open for a few moments and give everybody a chance to submit any questions at the same time. All right, thank you for everybody who participated in that. And we'll go ahead and move on to our Q&A. And we have quite a few questions for you, Dr. Collins. And our first one, we've had a few questions on this topic. For a patient that is obese, do you suggest using an adjusted weight or an actual weight when calculating calorie and protein needs?
Okay, well, yes. Obviously, that's getting to the issue. If you have a patient that's, 250 or 300 pounds and you use their actual body weight, you're going to come up with a very large number that's unrealistic. And again, why is that number unrealistic? Because you don't need to feed their entire weight. There are a lot of adipose, which is metabolically inactive. So for those of you that are not dietitians, what an adjusted body weight would do basically tries to account for taking off that metabolically inactive portion. There are different formulas out there that you can use to adjust it. Sometimes people just reduce their total weight by 25%, figuring that, they're about 25% fat and taking that portion off. But the answer would be yes, I would use an adjustment to come up with a more realistic number.
Okay. We've also had a few people ask questions about vegan patients. So what are the recommendations for vegan patients in order to meet protein requirements? And what are some ideas for incorporating and increasing protein in those?
Okay, well, I think that I've actually written entire articles on vegan patients. Certainly, we have many people who are vegan who are healthy and certainly meeting their protein needs. So I don't think that that should be too much of a problem. I think that there are different types of proteins that they can use, such as pea protein, that you just might have to look a little bit harder to find the particular items. Maybe those are not just the things that the facility, if you're in a facility, has right on hand, but certainly if you've been a vegan and you're living in home care, you know where to get these different products and which foods to eat. So I don't think that that should be a particular problem.
Okay. This person starts off with, this might be a naive question, but what is the protein source in protein powders for patients with allergies and or intolerances, especially with eggs?
Well, that's okay, the protein source, and certainly there's no naive questions, but the protein source, not to duck the question, but obviously for every product it's going to be different, so you'd have to read the label. But I would say in the vast majority of the products, it's either a hydrolyzed collagen or a whey protein. For wound healing in particular, certainly both are good sources of protein, whey and collagen. But for wound healing in particular, I like a hydrolyzed collagen because collagen, the way that collagen is built, amino acid wise, it has more prolines than whey does. And proline is another one of those key amino acids in wound healing. Remember when we were talking about vitamin C, we talked about the hydroxylation of proline to hydroxyproline. So as a proline donor, collagen does a slightly better job than whey. But as far as if someone has allergies, the only thing I can really tell you to do in the practical sense would be to particularly read the labels of what's in the particular product you're considering giving them. but collagen and whey are probably the first two ingredients you will come across.
All right. Are the zinc ointments absorbed into the bloodstream, and will they affect the zinc levels in your body?
Okay, topical zinc. That's an interesting topic. Topical zinc. When we're talking about zinc, we're talking about oral zinc, not topical zinc. As far as affecting your zinc status, this is something that we didn't mention, but certainly something good to know. It's very hard to measure somebody's zinc status. Drawing a serum zinc level, like taking blood to run a serum zinc level, doesn't reflect zinc stores. That only reflects the circulating zinc at the moment that you did the blood draw. So it's very difficult to see what somebody's zinc stores are. So it's a very difficult thing to even tell if somebody is zinc deficient. You'd really be better off doing some sort of a nutrition-focused physical exam and looking for telltale signs of deficiencies of various vitamin and minerals. But as far as topical zinc, that's really not where we were talking about. We were talking more about oral zinc.
Okay. What are your thoughts on products like Ensure and Live with HMB supplementation?
Okay, I've used that quite frequently. I think that is a good way to get the amount of HMB that would be efficacious in protecting muscles. One of the things I didn't show you obviously a whole bunch of studies here because I was really trying to keep today more practical focus so that you can really leave with some ideas of what to actually do with the patients in front of you. But when you look at the research, there's a great study published by a researcher by the name of Nicholas Dutz. I believe he was a citation on one of my slides, but he did a nice study on bed rest where he had one group of patients obviously acting as the control, and then the other group on bed rest getting an HMB supplement, and was able to show quantitatively that there was less lean body mass lost for the group that got the HMB supplement, exactly what I said it was going to do. But what's even more interesting is that he then, after the bed rest period, put them on a strength and recovery period. And during that period, the control group really wasn't able even to get back to their baseline. But the group that got the HMB not only put on more lean tissue, they actually exceeded their original baseline numbers. So HMB, I think, really does have that proof and that efficacy. There's plenty of studies that have been done on HMB that shows that even on patients on bed rest, it can help protect their lean body tissues. And that's really very exciting as a dietitian because there aren't too many ways that I can do that nutritionally. So as going back to the original question, a product that has added HMB, yes, I think that is something that I often do use and that I've had great success with.
Okay. Should a resident with a wound receive vitamin C and zinc supplements? I used to see this a lot, but not so much anymore.
Right, yeah. The reason that you don't see that anymore is because we don't really have the research that shows that that's a necessary step. And as I said, you might be giving them quite a bit of zinc already from the other supplements that you're giving them. So I don't know if they actually need additional zinc beyond that. Chances are they probably do not. We just don't see that because we don't have the evidence that shows that that's really necessary.
Okay. We've got a couple more questions for you.
Sure.
For a patient with ulcerative colitis, failure to thrive, and a stage 2 pressure injury at the coccyx with no appetite, what do you recommend? Do you recommend an appetite stimulant such as Megas or something else?
Okay. Not to correct you, but that would be pronounced Megas.
Megas.
Okay. Appetite stimulants just to make sure so everybody knows what we're talking about. Magistral acetate is what we're talking about. And that is one of the things that we use in an appetite stimulant. Is magistral acetate, is that its main indication as an appetite stimulant? No. That's an off-label use of it, but we do use it in some settings. Now, again, personally, I have used it on various patients. Some have had more success than others. The problem to me with any sort of appetite stimulant is that, yes, it might encourage the patient to eat more, but it doesn't particularly address the body composition issues. If you or I just started eating more, we'll probably put on more fat. We're not going to particularly put on lean. But if someone's really having a problem eating, I think that possibly it's something you can try for the right patient. Like I said, sometimes I've seen it work, sometimes I've seen it not work. What I do see work even better, kind of along the same chain of thought here, depending on what state you're in, is all of these medical marijuana products and all of these CBD products that are out there now. I've been doing more and more work in that realm as well, and things like, we used to use a drug form of it called Marinol, which some of you might be familiar with. These definitely seem to work, and if you can get, now there's CBD everywhere. You can buy CBD products, certainly in most places now, even on Amazon, there's hundreds of them that have CBD. If you're not familiar with it, is the portion that does not have the psychotropic effects. It does not have the THC in it, which is the psychotropic part of it. So you can isolate the CBD, and I've had very good results in giving patients CBD. I've got here a funny story for you here. I've got a 91-year-old patient that I have on CBD now, and it's working very well for her. And she told me, she said, "Nancy, I went to my doctor, and I told him you put me on LSD." And I told her, I said, "Not LSD." I said, "The doctor must have looked at you like you were bonkers." I said, "CBD." But yes, using that with great success now for various situations.
All right, wonderful. We've got a couple more questions, and our next one is for renal patients. Do you recommend the same amount of protein as you would for other patients?
Okay, when you say renal patients, of course, that covers a wide spectrum. If someone is a renal patient and they're on dialysis, then dialysis will take care of balancing them out. We don't restrict that too much. The more complicated situation is patients who have a renal problem and are heading towards dialysis and want to preserve their kidney function as long as possible. In those patients, yes, I would limit the amount of protein. That would be the indication for that. So here we have a situation where we have two opposite indications. We have a wound that needs a lot of protein. We've got a disease that needs a little bit of protein. So where do you fall? And the only way I've been able to reconcile that is to have a good heart-to-heart with the patient if they're cognitive, or their family members if not, and explain the situation. You need protein to heal the wound, but we want to limit protein to preserve the kidney function. And everybody's priority is different. That's part of the portion of practicing evidence-based medicine, is not only the research and your clinical judgment, but it's also the patient goals and desires. That also goes into there. And some patients understand that dialysis is in their future, and they understand that and accept it and want their wound to heal. But I've had other patients who will do everything they possibly can to stay off dialysis, and they understand that we're going to treat it that way. So I think you really need to have a heart-to-heart with that particular patient and family and set up some realistic goals that are in tune with what they are.
Okay, wonderful. Looks like we've got time for one last question.
Sure.
And for enterally fed patients with chronic wounds and high risks of aspiration, how should we recalculate the calorie and protein needs without putting them at risk for high residuals in aspiration?
Okay. Again, this would be very kind of patient specific. There'd be no number for an enteral patient that I can tell you that's for every single patient. I would need to know a little bit more of why is that patient on an enteral feeding. Obviously, their gut is functioning, or else it would be parenteral. But basically, I would calculate their needs. Let's put it this way: the only way I would adjust it would be if this particular patient is on a ventilator or in a critical illness or situation in an ICU like that. Then we do worry about refeeding syndrome and those kind of settings. But if it's more like a long-term care patient who's in a nursing home, then I would calculate that differently. So I would need to know a little bit more about that particular patient. But yes, in a ventilator situation, that would be calculated differently.
Wonderful. Well, I'd like to go ahead and thank everybody for all of your questions. We apologize if we did not have time to get to your question. We'd like to thank Dr. Nancy Collins one last time for an excellent presentation. As a final reminder, you will receive an email within 48 hours with your evaluation that must be completed before you can obtain credit. Thank you again for attending today's webinar, and keep healing.